Hello, welcome to Behavioral Health 107, Mental Health Disorders. Today we're going to be discussing somatoform, PTSD, and dissociative disorders. First, we're going to talk about somatic symptom and related disorders, including somatic symptom disorder, illness anxiety disorder, conversion disorder, factitious disorder, and psychological factors affecting other medical conditions. To be diagnosed, the individual must be persistently symptomatic, typically at least for 6 months. Somatic symptoms must be significantly distressing or disruptive to daily life and must be accompanied by excessive thoughts, feelings, or behaviors. SSD is characterized by recurring and multiple physical complaints that begin before the age of 30. These symptoms are difficult to link to an identifiable medical condition. Types of complaints generally include headaches, dizziness, chest pain, abdominal pain, and limb pain. The symptoms must be clinically significant, meaning that they require medical intervention and impair areas of functioning. The somatic symptoms cannot be intentionally produced or feigned, otherwise known as faked. Most current explanations focus on the concept of a misconnection between the mind and the body. So, the somatic symptoms are essentially medically unexplainable. There is nothing wrong with the person, but their symptoms are real. And they feel sick. But when you do an EKG, when you do a PET scan, a CAT scan, an MRI, they are fine. So in terms of the mind-body connection, it is as if the stress a person is encountering is manifesting itself through their physical body. Also, an association has been made between somatic symptoms and the level of social support a person has. So if someone is lonely or has no one to take care of them, they may have these symptoms as a way of getting someone to help them, but they don't realize that it is in fact a method of getting help without actually being sick. Alternatively, it can also be a way of getting attention from someone. The risk factors for somatic symptom disorder include a family history with genetics, early traumatic experiences, learning that illness does in fact attract attention, so a child may have learned to complain of symptoms for attention or personal gain, such as get well gifts. So a child may have to get their tonsils out when they're 7 or 8. They get a whole bunch of gifts, and suddenly they have a persistent sore throat despite no longer having their tonsils. It's not necessarily meaning that the child is faking it. It's they crave attention, and they have made that unconscious or subconscious connection in their own mind that if they complain about being sick, they'll get attention from mom and dad. A person has a higher risk of acquiring the disorder if a family member has it, or if a child observes his family member with the illness. Stressful life events and childhood physical illness may also be factors. Those with somatic syndrome disorder report more stressful and traumatic life events, including family conflict and breakup, physical and sexual abuse. A negative perception of their own body and health can also contribute to somatic symptom disorder. Ultimately, someone who's afraid of being sick can emphasize their negative symptoms because they are paranoid to a certain extent that they might be sicker than they actually are. So how do we identify somatic symptom disorder? While psychological disorders often underlie somatic disorders, those with SSD first seek medical assistance from a family physician in the belief that they have a physical ailment. These individuals may spend a lot of time in the mainstream medical system before receiving the psychiatric diagnosis treatment they require. Somatic disorders are estimated to occur in women about 0.2 to 2% and 0.2% of males. So it's not an overwhelmingly common disorder, but it is much more common in women than in men. The way to treat a somatic symptom disorder, there's multiple options, and the best option, is how it's developed. So a treatment course can include education, behavioral therapy to focus on behavioral change and reinforcement, cognitive behavioral therapy, which will help change the thought and behavior patterns that have unconsciously triggered the physical complaints, psychotherapy to deal with related family and social issues, hypnosis for the development of coping skills, family therapy, which can address diverse possible causes. In terms of medication, all of the studies show that medications are rarely successful for this condition. However, there are often comorbid conditions such as depression and anxiety, and they should be treated with the appropriate pharmaceutical interventions. Next, we're moving on to illness-anxiety disorder. IAD is a disorder involving excessive concern with one's health in the absence of objective, verifiable evidence of a health concern. Used to be known as being a hypochondriac or hypochondria. The behavioral characteristics of illness-anxiety disorder include frequent, dramatic statements regarding one's health, a lot of self-pity, exaggeration of the impact of actual disorders, dramatic response and preoccupation with minor injuries, claiming to have unverifiable disorders or a disorder persisting for an implausible length of time, and lack of response to reassurance from medical providers. So what we have here is someone who is convinced that they have a major disease, and they may have something very minor, but they're convinced that it's much more significant than it is. Symptoms of illness-anxiety disorder include preoccupation that one has or will get a serious illness, lack of somatic symptoms or mild somatic symptoms such as diaphoresis, which is excessive sweating, or slight tachycardia, which is excessive heart rate. There is a verifiable medical condition present, for example, a benign cyst, or the patient is in a high-risk category for developing a medical condition, for example, heart disease, but there are no current indicators of heart disease. The patient's anxiety or concern is out of proportion to the objective reality. The patient is hypervigilant about their health and is prone to feeling distressed about their health, changes in their health, or ambiguous symptoms. The patient will frequently monitor themselves for a sign of illness, such as checking their blood pressure or temperature several times a day. The patient will avoid medical care or evaluation due to anxiety about what they imagine will be found. This anxiety and preoccupation will have persisted at least 6 months, although the source of anxiety may shift. For example, fear of diabetes will ease when the person begins to fear that they have cancer. The anxiety and preoccupation with illness is not better accounted for by another mental disorder, including somatic symptom disorder, panic disorder, generalized anxiety disorder, obsessive-compulsive disorder, or a psychotic episode with somatic delusions. How to identify illness-anxiety disorder. People with IAD tend to overutilize healthcare services, have extensive medical care, invasive diagnostic procedures, and sometimes unneeded elective surgeries. They may crave the attention and care they get. Being the center of attention of a team of highly trained and skilled individuals can be rewarding in and of itself. IAD often begins in early to middle adulthood and is lifelong. That is equivalent to early adulthood starts around 18 to 24, middle adulthood, kicks in around 35 to 45. So you're looking at something that is not present usually as an adolescent, teenage years, but begins to kick in your 20s and 30s. Can begin after a medical scare, which turns out to be benign or not life-threatening. The onset can also be based on a life stressor. It can be learned from a parent or other family member. Approximately 2/3 of individuals with IAD are likely to have at least one other comorbid form of psychopathology, such as somatic disorder, OCD, GAD, which is generalized anxiety disorder, personality disorders, or post-traumatic stress disorder. So, what illnesses are not IAD? Münchausen syndrome, which is deliberately making oneself sick for secondary psychological gains, primarily attention from the medical staff. And we're going to talk about this in more detail later in this presentation. Münchausen by proxy syndrome, which is deliberately making one child sick for secondary psychological gains. Admiration of being a good parent by the medical staff. Thank God you're here. The child needs you. There are a lot of videos on YouTube that discuss Münchausen by proxy and how the parent will lie bold-faced to the authorities even though they're caught on camera smothering or poisoning their child. Malingering. This is the possibility that the patient is feigning illness for secondary gains, meaning they like being taken care of, or they're seeking to receive disability from the government. There's many reasons why somebody would feign illness. And then finally, drug seeking. Patients also oftentimes will get addicted to opiates or benzodiazepines such as Xanax, and the way to sustain their addiction is to present themselves at the ER or their primary care physician with a illness that would require them to receive a prescription for one of those medications. So the treatment for IAD is various types of psychotherapy where a person learns to respond appropriately to benign or ambiguous signals from their body. The first one is called Mindful Cognitive Behavioral Therapy, or MCBT. It combines the ideas of cognitive therapy with meditative practices and attitudes based on the cultivation of mindfulness. The other type is Rational Emotive Behavioral Therapy, or REBT. This type of therapy is based on identifying the illogical, unrealistic, and self-defeating interpretations of situations so that individuals can learn to overcome them. Medications are not in the treatment protocol except in cases of a comorbid condition such as OCD. IAD can persist through a person's lifetime, but can be managed with therapy. Next, we're moving on to conversion disorder. Conversion disorder is a somatic disorder characterized by a persistent change in motor or sensory function. Specific symptoms vary and can include weakness, paralysis, trouble with swallowing, unusual speech, numbness, unusual sensory problems, or a mixture of symptoms. Some patients experience an acute version of conversion disorder that lasts only a few days or less. For some, symptoms can persist for weeks or months. These symptoms are not faked or made up by the patient. Patients often have physical conditions unrelated to the current symptoms and may have mental health issues such as anxiety or depression. Conversion disorder is most common after a stressful life event or period of stress. It is 2 to 3 times more common in women than in men, and many patients have a history of childhood sexual abuse. So, in a sense, what conversion disorder does is a person has a situation that is extremely stressful for them, and their anxiety manifests by creating a situation in their health where they have trouble walking, or they lose their eyesight, or they can't feel things very well with their fingers. These are illnesses that are not faked by the patient, but are rather manifestations of the anxiety the patient is experiencing, but they're not physiological, they're psychological. Cognitive behavioral therapy works to identify and change thoughts that may be leading to physical symptoms. During psychoanalysis, the therapist works with the patient to identify unconscious traumas, life events, internal conflicts that may be causing psychological distress. Psychoanalysis is believed to be successful in treating 70% of conversion syndrome diagnoses. Hypnosis is also successful in treating conversion disorder. Symptoms seem to be relieved during the hypnosis session in about 80% of the patients. Because conversion disorder is comorbid with many other conditions, it is also important to treat the primary disorders in addition to this disorder. So if the patient also suffers from depression, it is important that the patient is treated with antidepressants to help them work through their serotonin imbalance. The next disorder we're looking at is factitious disorder. Patients with this disorder intentionally produce, feign, or exaggerate the symptoms of a disease, illness, or psychological condition with the aim of assuming the patient role. The motive varies, but may include a desire to seek comfort and attention, attempt to gain access to drugs, or a fascination with the medical field. The sufferer may have a personality disorder and/or unresolved issues from childhood, such as physical or emotional abuse or early detachment. The person may seek the attention and comfort one receives in a hospital environment. Consequently, when one symptom is under control, they may then fake a new illness. It is most commonly experienced by men in middle to late stages of life. These motives differ from those of malingering, in which one fakes symptoms to gain disability payments or medical leave. So as I mentioned before, Münchausen syndrome is a factitious disorder, and it is very serious, in which a person often visits doctors and hospitals and produces their own symptoms by taking medications. They will take substances such as bleach. They will literally drink bleach or inject bleach into themselves. They will contaminate their urine tests. They'll create their own infections. They'll add biological agents to their own bodies. And what they're doing is they are looking for attention, and they crave the attention that comes with being a very sick patient. As I mentioned before, the Münchausen by proxy, where the person gets their child sick, is even worse, and it is considered actually a crime, and people do go to jail when they're caught poisoning or trying to kill their child. So these are serious issues that go far beyond someone who just is attention seeking. When you're treating a factitious disorder, the current theories believe that it is vital to uncover the underlying reason for this behavior. A better understanding of the causes can lead to a more individualized behavioral therapy approach. When we confront the patient to address factitious disorder, it can be a very aggressive scenario. Also, diagnosis may be further confounded by pathological lying. So ultimately, cognitive behavioral therapy is the most successful type of therapy when managing this disorder. Antidepressants may be effective depending upon the analysis of the underlying causes. So if someone is suffering from depression and they're seeking out attention by feigning an illness, then it's a matter of balancing their serotonin. Psychological factors affecting other medical conditions is diagnosed when attitudes or behavior negatively affect the course or outcome of an existing medical condition. For example, severe stress can temporarily weaken the heart, or chronic stress can increase the risk of high blood pressure. Factors that can worsen a medical condition include denying the significance or severity of symptoms, denying the need for treatment, not following the prescribed treatment plan, not getting the recommended tests. So, you can have a very minor situation, but if you don't take care of it, it makes it worse, which means patient education and psychotherapy can help mitigate this condition. So we're going to move on to trauma and stressor-related disorders, including reactive attachment disorder, disinhibited social engagement disorder, PTSD, acute stress disorder. So, reactive attachment disorder, otherwise known as RAD, and this is an attachment disorder, describes a pattern of developmentally inappropriate moods, social behaviors, and relationships due to a failure in forming normal, healthy attachments with the primary caregiver in early childhood. A child who experiences neglect, abuse, or separation during the critical stages of development of the first 3 years of life is at risk of developing an attachment disorder. RAD is diagnosed when a child's social relations are subdued and he or she fails to engage in social interactions in a manner appropriate to his or her developmental age. So, for example, the child may exercise avoidance, hypervigilance, or resistance to social contact. Most 2- and 3-year-olds love to cuddle. So if a child is very resistant to cuddling, especially in the evening, this is a big red flag. The child may also avoid social reciprocity, fail to seek comfort when upset, become overly attached to one adult, and refuse to acknowledge a caregiver. So if a child is unwilling to be comforted by their primary caregiver and instead chooses a subordinate caregiver like a sibling, that's an indication that there's an issue. This most often occurs in children who are adopted after the age of 3. Other symptoms of reactive detachment disorder include failure to develop normally, poor hygiene, underdevelopment of motor coordination, and a pattern of muscular tension that goes beyond what is considered normal. Bewildered, unfocused, and understimulated appearance. Blank expression with eyes lacking the usual luster and joy. Failure to respond appropriately to interpersonal exchanges. The child may appear isolated and fail to make eye contact with other children. They may exhibit aggressive or manipulative behavior with other children. And the disorder must be present for at least 12 months. So if your 2-year-old is mad at you because you wouldn't give them a cookie and they stamp their feet and refuse to look at you, that is not reactive detachment disorder. That is a 2-year-old being a 2-year-old. If this is a child who consistently and persistently demonstrates this behavior over the course of a year or more, this is a red flag for reactive detachment disorder. Treating reactive detachment disorder focuses on trauma-focused cognitive behavioral therapy, or TFCBT, which treats the underlying attachment disruptions and promotes emotion regulation. It addresses the mechanisms of complex trauma that shift the brain into survival mode, i.e. the stress response, our fight or flight. The child is motivated by harm avoidance, so the child disassociates with any potential threats in his or her environment. With integrative play therapy and social learning provide creative channels through which children can learn social behavior and explore the underlying causes of their detachment disorder. Now, young children do not have the ability to self-reflect in the same way that adolescents or adults do, but what they can do is understand I'm happy, I'm sad. They can understand their basic binary emotions. So in play therapy, children learn to respect themselves, that their feelings are acceptable, that it's okay to express their feelings responsibly, to assume responsibility for themselves, to be creative and resourceful in confronting problems, to exhibit self-control and self-direction, to accept themselves, and to make choices and to be responsible for their own choices. Moving on, our next disorder is Disinhibited Social Engagement Disorder, or DSED. It is diagnosed when a child is very social with strangers and does not engage in selective attachments. Most children tend to become very shy around strangers. That is very normal. Mommy and daddy say hi to the nice lady, and the child may say hi and then hide behind mommy's legs. However, with children who suffer from disinhibited social engagement disorder, this child will indiscriminately and excessively engage in social behavior with strangers. They are willing to give hugs to anyone who approaches and to go with that person if asked. They also display a willingness to approach a complete stranger for comfort or food, to be picked up, or to receive a toy. And you can imagine that there are a lot of issues that could occur with that type of behavior. There is also a diminished sense of checking back, or absentee sense of checking back with the adult caregiver after venturing away, even in unfamiliar settings. This disorder must be present for at least 12 months again. So if your 3-year-old suddenly is no longer shy but wants to get to know everyone at a family reunion, they may just have a feeling of comfort because they know so many people there. Whereas if you take them to the park and on a consistent basis they tend to hook up with strangers, then you might have a bigger issue. Risk factors associated with and treatment for DSED. So the risk factors include severe neglect or deprivation in the form of consistent lack of having basic emotional needs for comfort, stimulation, and affection met by caregiving adults in the first 2 to 3 years of life. Repeated changes of primary caregivers that limit opportunities to form stable attachments, i.e. frequent changes in foster care. Play therapy and creative arts therapy are 2 effective treatment approaches. Because children with this disorder are overly friendly with strangers, the therapist can easily form a relationship with the child. However, children with DSED tend to have superficial relationships. It takes an integrative approach to develop a deeper connection with the child. Creative arts allow the child and the therapist to engage in activities that utilize multiple methods of expression beyond conversation. So if any of you have had children out there, you know that sitting side by side, playing with Barbie dolls, or coloring, or smashing up cars may be the most effective way to have your child interact with you or open up and talk about their feelings. So now we're moving on to post-traumatic stress disorder. PTSD is an anxiety disorder that develops after an event which creates psychological trauma, usually involving actual or threatened death, serious injury, or sexual violation. The exposure must involve directly experiencing the event, witnessing the event in person, learning of an actual or threatened death of a close family member or friend, or repeated first-hand extreme exposure to the details of the event. A diagnosis of PTSD is made when the symptoms cause clinically significant distress or impairment in social or occupational dysfunction for a period of at least 1 month. The symptoms cannot be due to a medical condition, medication, drugs, or alcohol. Symptoms for those older than 6 years of age include 4 clusters. Number 1, re-experiencing the event, recurrent memories of the event, traumatic nightmares, prolonged psychological distress. Number 2, alterations in arousal, aggressive, reckless, or self-destructive behavior, sleep disturbances, hypervigilance, increase in blood pressure and heart rate, hyperventilating, mood swings, fatigue or insomnia. Number 3, avoidance, distressing memories, thoughts, or reminders of the event. And number 4, negative alterations in cognition and mood, persistent negative beliefs, distorted blame, or trauma-related emotions, feelings of alienation, and diminished interest in life. Treating PTSD is very difficult. Cognitive behavioral therapy is most effective. Exposure therapy has shown a lot of promise in the last few years. Structured writing therapy, also very effective. More recently, virtual reality exposure therapy, or VRET, has been especially effective with veterans. Virtual reality exposure therapy places the patient in a computer-generated environment that simulates situations related to the cause of PTSD. Anxiety and fear related to the negative events are reduced over time through exposure. So, in a sense, they are being put in a virtual reality war zone where they are learning to master their fears and anxieties. Substance abuse is more prevalent among individuals who have PTSD, and the severity of symptoms is more pronounced for those with alcohol and other drug problems, which can complicate treatment plans. Moving on to acute stress disorder, which is very similar to PTSD, there is a condition that is a short-term condition that usually lasts for about a month or less, whereas PTSD can last for several months or even years. Another major difference between acute stress disorder and PTSD is the diagnostic emphasis of dissociative symptoms present in acute stress disorder. Dissociative symptoms, such as feeling detached from an experience, feeling numb, or being unable to remember traumatic events, are believed to prevent the victim's ability to deal with the problem, even when they receive treatment shortly after the trauma. If acute stress disorder is not properly treated right away, it can lead to PTSD. The primary goal of treatment for acute stress disorder is to prevent this disorder from becoming full-blown PTSD. Crisis therapy and debriefing are both effective treatments. Crisis therapy is used to promote a sense of safety after a trauma, calm the victim, promote a sense of self-efficacy, encourage community or victim connectedness, and instill a sense of hope. Debriefing can be done as in group or individual therapy. When an entire community is affected by a catastrophe, such as a school shooting or a natural disaster, group therapy is effective and very helpful. During individual therapy, victims of trauma can share their experiences related to the traumatic event and quickly develop coping skills. In the long term, stress management techniques can help any residual anxieties that persist. So, moving on to our final topic, which is dissociative disorders. And we're going to talk about dissociative identity disorder, which used to be known as multiple personality disorder, dissociative amnesia, which used to be known as dissociative fugue, and depersonalization or derealization disorder. Dissociative identity disorder, again, used to be referred to as multiple personality disorder. The key element in this diagnosis is the presence of at least two distinct and separate personalities within an individual. Although multiple personalities, otherwise known as alters, exist within a single person, only one is manifested at a time, each with its own memories, behaviors, and life preferences. The alternate personality is not a result of substance abuse or a medical condition. This condition is typically seen in women, and the number of alternate personalities increase with age. The average age of onset is somewhere between the ages of 5 and 10, which leads us to why it develops. It is usually a response to extreme physical, emotional, and/or sexual abuse. It is literally a way for the brain to protect the identity or sense of self of a person who is going through unimaginable trauma and has no coping skills to manage those traumas. Symptoms of dissociative identity disorder include inability to recall large memories of childhood, lack of awareness of recent events, and if they do remember, inability to explain them. For example, not being able to explain how the patient got somewhere or how they acquired a possession, having lost time or frequent memory loss, flashbacks or a sudden return of memories, feelings of disconnection or detachment from bodies or thoughts, hallucinations or voices, so-called out-of-body experiences, self-harm or suicidal thoughts, changes in handwriting. Oftentimes you'll see with someone with dissociative identity disorder, one personality may be right-handed and another personality may be left-handed. Functional changes from nearly disabled to highly functioning. Less commonly observed manifestations observed in patients with dissociative identity disorder include mood swings or depression, anxiety, nervousness, panic attacks or phobias, eating and food issues, unexplained sleep disorders, headaches or general pain, and sexual issues, sexual addiction, or sexual avoidance. There are 3 celebrities who have come out of the so-called closet and have indicated that they have been diagnosed with dissociative identity disorder. Adam Duritz, the lead singer of Counting Crows, Nina Simone, who was a jazz singer and pianist, and Herschel Walker, who was a former NFL running back. He wrote a book about his experience of learning that he had dissociative identity disorder. How do we treat it? Well, the primary goal of treatment is to integrate the personalities to attain a unified self for the client. Phase 1, establish safety, stabilization, and reduction of symptoms. Phase 2, confronting, working through, and integration of traumatic memories. And Phase 3 is integration and rehabilitation. The identity in control may be unaware of the other alternate identities or disown them. It is critical that the therapist helps the identities become aware of each other, legitimize them, negotiate, and resolve their conflicts. In addition to psychotherapy, some individuals may also benefit from cognitive therapy, family systems therapy, creative therapy, i.e. art and/or music therapy, or clinical hypnosis. There is a high chance of relapse when the patient faces significant life stress. Moving on to dissociative amnesia. This disorder involves the temporary loss of recall memory caused by dissociation, which may last a period of seconds or years. The interruption in memory may be voluntary or involuntary and is most often a result of psychological trauma. Brain imaging studies have identified changes and fiber degeneration in the right temporofrontal cortex area in individuals with dissociative amnesia. For those of you who have seen the Bourne movies with Matt Damon, this would be an example of dissociative amnesia where he just can't remember who he is or where he came from, but he still has the skill sets that he was trained with in his younger years. Symptoms include unable to recall autobiographical memory associated with traumatic event, the inability to recall the traumatic event which created the distress. The memory dysfunction does not have a physiological cause. It is not dissociative identity disorder, and it is not the result of substance abuse or another substance. The individual may have partial memory recall through flashes or nightmares, and it is often comorbid with post-traumatic stress disorder. It can also involve the individual engaging in travel away from their previous home due to a lack of memory. So oftentimes you will find people who are on a train or a subway and they just have no idea who they are. So how do we treat this? Some people have a spontaneous recovery and their memory is restored. However, for those who do not, it can be very difficult to treat and may never be resolved. Memory recall is attempted using dream analysis, computer aids, visual imagery, hypnosis, which is very controversial because there have been many instances of false memory recovery where people have what they believe are memories but are actually things they've seen on TV or ideas that have been planted in their minds, which are in fact just not true. And stress reduction. Reducing the underlying symptoms helps ease the stress associated with these repressed memories. Finally, we're going to talk about depersonalization or derealization disorder. The patient feels as though he or she is detached from the self, from their environment, their feelings. It's like they feel as if they are watching themselves from a distance. It is usually triggered by a traumatic or stressful event, and the average age of onset is 16 and generally stops occurring around age 25. These episodes can come on suddenly or persist for months or years. Emotional abuse is the most common factor associated with depersonalization and derealization disorder. During episodes of depersonalization or derealization, the sensory cortex is overactive, so it is like the brain is feeling a sensory overload. The amygdala, which regulates emotional response in the brain, has been found to be underactive in individuals with depersonalization, derealization disorder. This can result in a sense of emotional numbness. Although it is common for people to feel a sense of detachment during a time of crisis, it generally goes away after a few days. Only if it persists beyond a few days and it impairs social and occupational relationships should treatment be pursued. So how do we treat it? Medications such as antidepressants and anticonvulsants are very helpful. These drugs change the way the brain responds to emotional and sensory stimuli. The psychoanalytic model sees depersonalization and derealization disorder as a defense against internal conflict or threat of the self, usually the result of childhood abuse. From this approach, depersonalization, derealization disorder is treated by identifying and overcoming childhood abuse. Additionally, coping skills are taught to assist the patient learn to manage and adapt to stressful situations. Here are some of the works used to develop this PowerPoint. and finally the rest. If you have any questions, please feel free to email or text me. Thank you very much, and I hope you have a wonderful day.